Hi there, my name is Alainna Jamal, and my proposed study is titled The Prevalence of Carbapenemase-Producing Enterobacterales, or CPE, among patients admitted to acute care hospitals from long-term care facilities in South Central Ontario, Canada. We know that antibiotic resistance has had a devastating impact on health systems, and economies worldwide. This study will focus on CPE, which, as you're all aware, are at the very top of the US CDC and WHO's list of priority pathogens of concern. In terms of the epidemiology of CPE, where I am, the Toronto Invasive Bacterial Diseases Network, or TIBDN, has performed population-based surveillance for CPE in South Central Ontario since it emerged here in 2007. CPE remained relatively uncommon in South Central Ontario, but we've seen a doubling in the incidence about every 2 years, and the proportion of our cases associated with local healthcare as opposed to healthcare abroad or travel has increased to about 30%. This suggests non-trivial local transmission and a need to optimize our local prevention and control measures. One way we might do this is with enhanced admission screening at acute care hospitals, which currently focuses on patients with prior healthcare abroad. Long-term care facilities are an important potential reservoir for CPE to consider. Despite long-term care facilities in the US and other countries being an extremely important driver of CPE transmission, here in Ontario, we're much earlier in our CPE emergence, and our long-term care facilities are actually quite distinct. They're purely residential with no invasive devices. And so because the epidemiology of CPE in long-term care facilities hasn't been studied in South Central Ontario or other parts of Canada, we're not sure whether it's cost effective to screen this population on admission to our acute care hospitals. Given this gap, our aim is to determine the prevalence of CPE colonization among patients from long-term care facilities being admitted to our acute care hospitals in South Central Ontario, because this will inform our admission screening practices. And we hypothesize that the prevalence of CPE in this population will be above 0.015%, which from prior work we know is the prevalence above which screening for CPE is cost effective in our setting. All 24 of our TIBDN acute care hospitals screen patients from long-term care facilities on admission for MRSA or VRE with rectal or pooled nasal rectal swabs. In this study, starting in June 2022 for 5 to 7 months, we'll prospectively collect all of these leftover MRSA and VRE admission screening swabs from our long-term care patients and test them for CPE. We'll use our current methodology, first multiplex real-time PCR for carbapenemase gene detection, and if PCR positive, then culture to identify an organism. In terms of our sample size, we think that the prevalence in this population of interest will be above 0.5%. But if the prevalence is 0.15% or 3 colonized long-term care residents among 2,000 samples, then the lower bound of our 95% confidence interval will be above the cost effectiveness threshold, thereby justifying admission screening for patients from long-term care on admission to our acute care hospitals. There are a number of things to gain from this study. First, it'll fill a gap in our knowledge of long-term care facilities as a potential CPE reservoir in Ontario and other places with similar types of long-term care facilities. Second, it'll directly support our decision-making around admission screening. We're very well connected to infection control programs and expert guideline committees across the province. So if admission screening practices need to change, we're well set up for knowledge translation and implementation. Third, this study will tell us how much we need to be focusing on CPE in long-term care facilities, and I do plan to use these isolates in a future study looking at the genomic epidemiology of CPE in our population base. Finally, thinking more broadly and long-term, we hope that lessons learned from our studies of CPE in Ontario can be applied to the emergence of other antibiotic-resistant organisms in future. This study is feasible because of the well-established TIBDN research infrastructure that we have. My mentor, Dr. Alison McGeer, is a very experienced infectious diseases physician and epidemiologist, and I've assembled a team of co-investigators with the relevant multidisciplinary expertise. Some, not all, are photographed on this slide, and many have been working on CPE since it emerged here in 2007. We're asking for about $20,000 US, mainly for personnel and consumables. I thank you for your interest in this study, and I look forward to the Q&A in Colorado Springs in April.